All right, guys. So another morning of analyzing ECGs. Tired of it now, I'm sure. Eh? Yeah, you have to. That's the third part. Eh? All right. So today we're going to analyze another one. So let's just have a look first, just a reminder. Okay. So it looks scary. All right, but you're going to get through it. And just adjust this a little bit. All right. So I always put the slide up just so that you guys don't forget, right? To break things down into their little boxes, right? That you analyze axis, analyze rhythm, how you analyze the rate, how you analyze each zone, all right? So even something that looks a bit scary, does look a bit scary, I mean, there's a lot of things that are going on there, can easily be broken down. Monisville, how are you? Okay, so let me just hide this a little bit. And then we get into it. So first, let's start with the history, right? So 45-year-old man, severe left pressure, chest pressure, nausea and dyspnea. So even before you look at the ECG, what are your considerations? What are you thinking of as a possible? Let's say you haven't even gotten to this part, right? What would you already be thinking of? Severe left chest pressure, not pain, right? Nausea, dyspnea. Got to have a list of differentials in your mind already. Very good. Ischemia should be up there because of the chest pressure. All right. Anything else? Thinking of particularly with dyspnea? Dyspnea and left chest pressure? Pulmonary embolism? Agree? Should be thinking of things like that. Okay. Nausea? Okay. That might be related to MIs as well. Simple gastritis, pancreatitis, a lot of things. They can be. But would they necessarily give you left chest pressure? They can, but maybe not. All right. So you're not sure, because there's a few differentials that are popping around with it. So the first thing that you need to do is that you go and you do an ECG, because you want to make sure, is this cardiac or not cardiac? Because cardiac and pulmonary embolism are going to kill your patient quite quickly. And if you can rule those out, then you've got time to check for the others. Agreed? All right. So let's look at the axis first of all. So we look at leads 1 and lead AVF, which are they both pointing upwards. All right. So that means, come on, this should be like second nature, right? Normal axis, very good, yeah. All right, that's good. All right, so let's look at the rhythm. All right, so first let's try and find P waves. Can you guys see P waves anywhere in there? Should be some somewhere. I can see some hiding over there. Let me just put on the pointer, I think easier. There's some P waves hiding over here, all right? You can't see them too well here, but you can see them around, all right? So the P waves themselves, how do they look? Normal, abnormal? Just their look. Yeah, there's some there. They look relatively okay. They look relatively okay. So we can assume that this little hump that we're seeing over here is a P wave as well. So our PR interval is going to be 1, 2, 3, 4. So that's within normal, except for here, all right? We're going to come back to that just now, okay. And then the next thing is our QRS complexes, are they narrow or wide? Narrow actually, eh? Narrow, because remember, this is actually a QRS complex, this little thing here. And then once it changes, that's your ST segment. So all that we're seeing that making it look wide is actually an ST segment. So you're not wrong to say that it's wide, but you understand why it isn't, you know? And most particularly, you can see the thinness there and see the thinness there, all right? So these are actually thin QRS complexes, all right? And then the last question is, there's a QRS after every P. In other words, is the ventricle contracting after the atrium for the majority of the time, except for one here, all right? Otherwise, it seems to be okay. Is it regular? Actually, majority of the time, it is regular, except when you get to there's one beat in the middle of everything over here, all right? And even this little beat has a little P wave in front of it, a very short PR interval. So that tells you that the atrium contracted prematurely, all right? Because we can see it. We can see that the atrium contracted, but it contracted before it was supposed to. So this is what they call a PAC, premature atrial contraction, which is something that everybody goes, ah, what's that? It's so easy. That's a premature atrial contraction, all right? So it's just that the atrium, for whatever reason, has decided it's going to contract early. It is a, what you call it, it can point to a few things, but I don't want to get into that too much now. You know, things like what you call it, accessory pathways and things like that, but we're not going to concentrate too much on that. Just that we can't really say we've got a sinus rhythm, but for the majority of the time we do. Let's say if we found nothing else wrong, you would go and do rhythm strips and check the patient for 3 or 4 minutes, see if this is recurring on a regular basis. But we can see there's something else wrong. So we're not going to spend 2 hours looking at why the rhythm is not 100% okay. Right? And the rate for this patient will just work out quickly. It's about 1, 2, 3, 4, so about 75 beats per minute. So not a tachycardia, not a bradycardia. Now let's get to the meat of it. All right. So I think we can all agree this looks like an ischemia. Okay. But the question is where? All right. So this is where the zones come into it. All right. So who remembers any zone from anywhere? Any zone. Who can tell me what's the inferior zone, lateral zone, septal zone? All right, let's start there. All right, no problem. Let's start. It's no problem. So V1, V2 is the septum. What do you see over there? Very good. You do see ST depressions, quite significant ST depressions. Agreed. All right. Then what's the next zone? If we had to go to V3, V4, for example, just keep it in context. Very good. So what do we see in the anterior zone? Very good. And quite significant ST depressions as well. Agreed. What about V5, V6? They are what part? What zone are they known as? AVL, very good. With lead 1 and AVL being known as the high laterals. Very good, yeah. So we'd expect them to show all a similar picture. Eh? So what do we see in V5, V6? In V5 we see here. Very good. And in V6 we see here. It actually looks like ST elevation. Yeah? All right. And then what do we see in leads 1 and AVL? ST depressions. In other words, V5, V6, leads 1, AVL, they all kind of match. This is V6, what the hell's going on? All right. So there's a few questions that could be, there's a few reasons. Number one, it could be incorrect placement of the lead. Maybe somebody didn't put it in the right place, put it a bit too anteriorly, not laterally enough. There's a few things that could cause it. Or there's something else that's happening in the heart on that lateral side. Is it also being affected right towards the end? Because remember, you're looking towards the back area of the heart. All right. That's a clue actually to what's happening today. All right. So we kind of know that we've got this whole bunch of ST depression. What's leads 2, 3, and AVF? Which zone are they? Very good. And what do we notice in lead 2, lead 3, and lead AVF? Very good. ST elevations. All right. But what's so odd about these ST elevations? What do they look like? Tombstones. That's the right word, Dr. Skuriko. Right. Don't they look like tombstones? All right. So do you think people made up that term just because it looks like it? Yeah, because it actually means your patient's chance of demising are quite high. Eh? So that's why they call them tombstones as well. So it's got a double meaning. It looks like a tombstone, but it actually indicates your chances of going to your grave are quite high. Right? And what did we say about, last week we talked about this. We said about the ST elevation in lead 3 is higher than lead 2. It implies that which side of the heart is also affected? Not just the left-hand side or the inferior part, but also the right-hand side. Right-hand side, right? So remember that ST elevation in lead 3 greater than lead 2 implies that you've got a right-sided, what you call it, involvement, which means we don't give, we spoke about it, TNT, all right? So that's the first thing that we know. And what do we see in AVR, our last one? We see an ST depression, okay. So we basically have a similar situation to what we had last week, right? Where we've got this right-sided MI, inferior with right-sided extension. And we've also got this little abnormality in that we've got V6 that's showing a little ST elevation, right? Now, this doesn't always happen, but in this particular case, the reason why I wanted to bring it up, it kind of fits the picture as well. We've got nausea, we've got left chest pressure, we've got a bit of dyspnea because of the MI. The nausea is more related to the inferior part of it. But what I wanted to introduce you guys to today was V1 and V2 being as depressed as they are. Okay. If we look at the heart, V1 and V2 are sitting in the anterior part of the heart. Agreed. And they are mainly looking at which part of the right ventricle and the septum. All right. And then what's right at the back? The posterior part of the heart. Agreed. So how do we check the posterior part of the heart? Just on a normal ECG, we actually look at V1 and V2. because they are actually looking at that, all right? But they are looking at it from the opposite side. They aren't actually placed looking at the posterior part. They're kind of looking at it from the opposite side. So just like we said, with leads 2, 3, and AVF at the bottom, everything on the opposite side should be seeing the opposite. So even though we're seeing ST elevations here, everything else is seeing ST depressions because it's looking at it from the opposite side. So it's a reciprocal change. So can I ask you, could this be that the posterior part could be having ST elevations? It's very possible. It's very possible. Okay. So this is the one thing that we need to check whenever we see these inferior right-sided MIs. And this one here, V6, just the fact that it's going up a little bit also gives you a little clue that this could be posterior. Because V6 is also placed more towards the back. So it's also looking towards this posterior part of the heart. And we start seeing this little ST elevation. All right. So let's have a look and see how close we are to a correct answer. All right. Oops. Sorry. Just stuck. All right. So we have sinus rhythm with occasional premature atrial contractions, which we said, right? The rate they worked out to be exactly 80. Left ventricular hypertrophy. All right, so that we missed out on. Let's go back and have a look. Why would they say left ventricular hypertrophy? It's based on the extent to which the, QRS complexes have gone up. So we did miss that, all right? That's for sure. There is a bit of left ventricular hypertrophy. Acute inferior MI with posterior extension, all right? So let's read about it, then we'll try and logic it out a little, all right? So posterior MI usually occurs in association with inferior MIs, all right? Less often in association with lateral MIs, okay? Why do you think that is? It's because of the blood supply. Okay, it's because of the blood supply. What are our arteries that are running down that side? Okay, what are our arteries? See, everybody, we're going to go and learn this, all right? Left anterior descending, left coronary, left anterior descending, and right? What's it? Yeah, go and learn it, all right? Then you'll see why it passes to the back, all right? Circumflex, all right? So it passes mainly to that side, okay? And then certain branches of the left coronary artery also pass towards the back to provide blood supply, okay? But when you look at it, it's just interesting, okay? So, and they very rarely occur in isolation, all right? So the majority of the time it's with an inferior right-sided MI, all right? Acute ischemia and infarction are associated with ST segment elevation, T-wave inversion, and development of Q waves, all right? So because the standard precordial ECG primarily leads V1 to V3 provide an inverted image of the posterior portion of the heart. Like we say, they're sitting at the front. So they're looking at the back, but from the wrong side. Okay. Acute PMI will be associated with inverted findings in those same leads. Now, does this mean every time you have ST depression, V1, V2, V3, it's definitely a posterior MI? No. Doesn't mean that. It just means there's a likelihood of it. All right, so we're going to check how we're going to look at it, all right? So in other words, acute PMI will produce ST segment depression, large upright T waves, that's the second criteria, all right? And progressive development of large R waves in leads V1 to V3 as seen in this case. Nobody's going to remember that when we walk out from here, okay? Not even me. So we'll check how do we make sure, all right? Another method of detecting acute PMI is to perform an ECG with posterior leads. Okay, I'm going to show you that now, all right? So using the standard ECG, simply place leads V5 and V6 on the left back, just infralateral, inframedial to inferior pole of the scapula, evaluating the standard ST segment, invasion, TOS, QS, blah, 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 blah. It's a long thing to read, all right? Let's have a look and see what the heck they're actually talking about. So this is what they are talking about. Okay, so remember we said there's no such thing as a 15 to 18 lead? All right, there is, it exists. This is a 15 lead ECG, all right? So basically all that you do is you take V4, V5, V6, and you're moving it around the back, all right? V4 gets placed on the posterior axillary line in actual, all right? So it's a bit off-putting, but it's more or less around there. V5 becomes V8. It sits below the tip of the scapula. If you're not sure the height at which you go, you feel the tip of the scapula, and V9 is in that same plane, just paraspinal to the left, all right? So what do we expect to see now? Now we expect to see ST elevations, all right? But how strong are they going to be? Not as strong. Why? Because the heart is further away. There's lung tissue in front. there's bone in front, there's muscle, back muscle. So we're still going to get an electrical signal. It's not going to be as prominent as what you would see from the front, where your heart is quite anterior to the chest over here. Okay, so what we do is that we, like I say, we now move them around. Okay, so we can take V1, V5, and V1, V2, V3 and change it to V4, V5, V6, but that's not normally done. Normally, all we do is take V4, V5, V6 and change it to V7, V8, V9. All right, and that's when you start to see the ST elevations. Okay, now the most important thing is that when you do this type of an ECG, whether you're checking for right-sided or you're checking for a posterior, is to label it. Otherwise, nobody has an idea of what you are seeing. Because then you've got two conflicting ECGs sitting in your file. You've got one that's showing a whole lot of ST depressions, and then you've got one that's showing ST elevation. Now, which one is which? When were they done? So that's why you need to mark them. 15 lead, 18 lead, scratch out all of that and put which leads you actually used. So what happens is that the person can actually see what's going on. Now, in this case, we would have suspected a right-sided and a left-sided. So you do an 18-lead ECG, formal, do a formal 15-lead ECG, and check. Why is this so important? Why is it so important that we know this? Because surely we could just look at the front and say, yeah, it must be, let's treat the patient. Until you have confirmation, you don't know how aggressive to be with your treatment. Okay, the more ST segment elevations that you have, and the higher that these ST segment elevations are, and the more zones that are involved, the greater the risk to your patient. All right. Take a patient, for example, where we can barely see the ST elevations here in the inferior leads. There's hardly any ST depressions, very minor. There's no involvement of the posterior side. Are we as worried as we are with this patient? No, of course not. We still have to treat them. But this patient is somebody that we know is going to go down very quickly. We're going to try and thrombolize as quickly as possible, or we're going to do PCI as quickly as possible. Okay, we're not going to wait for trop TAs, CKs, for the physician to drive out from home. If he doesn't or she doesn't drive out from home, we're going to call the HOD. We're going to call the medical manager. We're going to call everybody and say, this patient is dying and this person is sleeping at home. Agreed. That's what we're going to do, as compared to somebody with a half a block, where they tell us wait for the trop Ts, say, yeah, okay, let's wait for the trop Ts. Let's just make sure, because we're also not 100% sure whether it's up or not. Okay, so you understand the reason why we have to know it. Okay, so this is why we need to do all of these things, all right, so that we can see what's going on, all right? So let's just remember some general considerations. We're almost finished. It's not a long one today. So like we said, posterior MIs normally occur in conjunction with inferior MIs. So we avoid TNT for the reasons that we mentioned last week, and less commonly in conjunction with lateral wall ischemia, which is what we're saying in anyway, all right? And occur very rarely in isolation. But what happens when they occur very rarely in isolation? You get pain will mainly be over the area of the central thoracic spine to the tip of the scapula. Okay, but normally the pain is overshadowed by concomitant infarcts. So that means you'll have pain of a lateral infarct or an inferior infarct as compared to the posterior side. But what happens if you do get a posterior? You've just got pain over the T-spine. So your patient comes in complaining of unexplained pain over the T-spine. Worrying, huh? Do a T-spine X-ray, NAT, go home. We all do it. That's the thing. We all do it. Even I'll do it. And I'll try and find something on the T-spine to explain. Yeah, that bone just doesn't look, I think there's an osteophyte there. So go home. You know what I mean? Which is fine. It happens because it's such a rare occurrence. But it just shows you, when you have any pain above the pelvis that you cannot explain, it takes you 5 minutes. Do an ECG. It may turn out to be completely fine, and okay, you wasted your 5 minutes. But what if you find something? Do you get what I mean? Remember, at the end of the day, your job is to look after that patient. All right. So now this doesn't mean somebody was in a PVA and they've got thoracic, please do an ECG. No, I'm not saying that. But if it occurs in isolation, then please, 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 there's no harm in doing it. To be dead honest, if a patient comes in with unexplained dental pain, they've been to the dentist can't find anything. Unexplained ear pain, unexpected headaches, nothing is figuring out what's going on. There's no harm in doing this. Jeez, I don't know what happened. This whole thing just froze up. Okay, there we go. All right, no problem. I say that, but it's still kind of stuck. All right. Okay, so if there's no questions, then we'll all get back to work. And all right, no problem. Okay. Spiwe, I forgot to tell you, when I drew up the roster the first time, I thought tomorrow was a public holiday. So I didn't put you, I had put you not on, but you are on tomorrow. Okay, just letting you know. All right, okay, I'll see you. All right, okay, no problem.